Well, it's my great pleasure to introduce Dr. John Cookwood. I can say without reservation that he is one of our major thought leaders and clinical researchers in the world for melanoma. I have known Dr. Cookwood for about 17 years now. He chairs the Melanoma Committee at the Eastern Cooperative Oncology Group and was the principal investigator for the major international trials using interferon to treat melanoma. He received his MD degree from Yale and continued in his residency there, and later his fellowship in hematology and oncology at Yale too. After starting his academic career at the Peter Brigham Hospital in Boston, it's almost a tongue twister, he went back to Yale and then to the University of Pittsburgh School of Medicine. For 10 years, he was the chairman and professor in the Division of Medical Oncology and is now the director of the Melanoma Center, a professor and vice chairman for clinical research in the Department of Medicine, and professor of clinical translational sciences at the University of Pittsburgh. His service and contributions are innumerable. He is an author or co-author on over 267 peer-reviewed papers and 164 invited reviews and book chapters. Again, it's my great pleasure, and I thank him so much for coming today. Dr. John Cookwood, please go.
Thanks, Bruce, for that very gracious introduction. So, you all are the focus of the teaching that I think all of us in academia would like to do. Everybody thinks that it's the residents or the fellows, the students who are in our clinics that we really would like to teach. But I have to tell you, it's really our patients and their families, because your impact as you convey any of the information we're so lucky as to be able to give to you will be felt far more than literally any of the other teaching will do. So it is with great relish that I'm going to try to cap and pull together what Henry has just presented in a very lovely fashion, what Ed Crum before and Pierre and Bruce have summarized in terms of the trial options that are open for patients with melanoma. And what I'm going to try to do is to present to you where I see our direction, but I'm also going to give you the questions, the hurdles, the speed bumps that we see in each of the areas of putative progress. And so all of this takes a lot of support, and I just thought I should credit our Cancer Center Support Grant, where we just brought Nancy Davidson up from Hopkins to lead, ECOG, and the Intergroup, which you've already heard is the University Without Walls, through which all of the studies that we're talking about get done, because without these, we wouldn't be where we are today. We were fortunate 3 or 4 years ago to get a SPORE, a specialized program of research excellence. This allows the 27, 28 faculty who work on melanoma with me to develop new trials that within a span of 5 years are supposed to get to the clinic to make traction, to make a difference. And then because Valerie is here and we've been working together on a mutual love affair with what is an international melanoma working group, to really bring this together at a world level so that trials would be offered not just in Pittsburgh or Cleveland, but really in Kiel, in Essen, in Naples, down under in Sydney, with the very same goals. And I think, as I point to in the close of my talk, we've actually finally gotten there with a conceptual commitment to do studies, which has been 5 long years of work to get it done. So everything we do is multidisciplinary. This is really just to highlight the fact that the issues are multidisciplinary. The surgeon is obviously the person who can cure the greatest number of patients with melanoma. It isn't just the primary spot on the skin in 95% of patients, but the regional lymph node spread, which holds the key to our success. And we've only very recently been able to splice gears with our surgeon so as to study the lymph node in almost every patient that gets operated, because that's where the story about what's going on in the host battle with the tumor will be told. Distant disease, where our surgeons get tumor tissue, it teaches us nothing. We learn nothing from that unless that goes into the tissue bank. And so I exhort you as our patients to ask your surgeons, are your tissues going into a bank? Because if they aren't, they don't tell us what we need to know about the disease. Radiotherapy in Pittsburgh had the first Gamma knife, so we've treated now several hundred patients with brain metastases. Actually have patients 10 years after brain metastasis who are still living. When I was at Yale for the 15, 16 years, we didn't have Gamma knife. We had nobody who made it past the magical 2 or 3 years. Stereotactic radiosurgery is a huge advance. We won't say anything more about it today, but you need to know about it because it means that the brain metastasis is not the brick wall at the end of the road. And medical treatments, being a medical oncologist, is where we're going to turn to now, because I think the medical treatments have, in the end, some of the greatest potential, sadly to the present, mostly untapped potential. So these are the 3 areas of medical intervention that Henry has nicely already introduced. Chemotherapy, killing the tumor cell with a drug that either binds the DNA, kills the cell through other mechanisms. Targeted therapy, where we're killing the tumor by blocking up the engine, throwing a monkey wrench in the drivetrain, or immunological therapies, where many of us began our scientific careers interested in what the dialogue is between the tumor and the host. What is being said, because in the end, we know melanoma is worse of a disease in patients who have a paralyzed immune system, in patients who are transplant recipients have very potent drugs to allow the transplanted organ to stay, in others with other immune deficiencies, but this has also only recently become clear. I want to start by saying all these clinical trials that you've heard a lot about have told us very little in 35 years. Perhaps the most sobering experience of my life is to gather the other 5 or 6 leaders of the cooperative groups in this country and in Canada to summarize the last 35 years of trials that we've done in what is called phase 2, exploring new drugs for efficacy, where this so-called meta-analysis crunched together all of those 42 phase 2 trials and asked, what did we really do with these treatments? The endpoints are very important, and the endpoints that I think we all agree make a difference are survival, but do endpoints of lack of progression? Tumor doesn't get bigger. Do those teach us things that will ultimately teach us about better survival? Response rate, you heard about from Henry and from Pierre. Does response, does shrinkage of the tumor teach us that the patient will live longer? Sadly, to the present, not. And in that interesting result that Henry presented, and I'll come back and bore you with the results of the Epilimab trial. I practiced that. Basically, the Epi trial, the response rates are 5 or 10% for a 30% improvement in survival. So what do we make of that? And so we took all of these data, all of these trial results, and we said, what could we learn from them? So this isn't as confusing as it looks to you, and I don't want you to read any of the numbers. I just want you to see that if we have more patients along the bottom axis, the number of patients grows from left to right. The more patients we put on clinical trials, the closer to something that is true accuracy, to truth in clinical trials, is arrived at. And so on the left, we have survival. And the farther we go to the right, you see we come to a number which is about 25% surviving at 1 year. And that is the reality of the patient situation for those patients who entered these trials. On the right, the panel says progression-free survival. Again, Henry's introduced that. But the lack of progression came to a number of 15, 18% at 6 months. And these are the nature of the disease. These had not been influenced by any of the treatments, because when we came to the statistical analysis, it turned that none of these 42 trials had really hit the ball out of the park. None of these had really changed anything. So what we used these for were to say that if in a new trial we do something which is double the 15% progression-free, and if we do it in a number of patients that's meaningful, which is not 10, not 20, but often 50, 60, or 70 patients, then we should believe that. And so what this has done is, I think, for the future, and the 1608 trial that you've heard about twice now from Ed and from Henry, is one which will actually take the numbers that we said in this summary paper should be used to assess the benefit of a treatment, and we'll do a trial where we actually test it in real numbers in a phase 2 setting. And so I think these are really just to set new benchmarks to say, when we have a treatment that works, can we really hope to discover it? So you've seen a couple of versions of this. This is the list, the laundry list of all the systemic therapies we have. It's really there to sober us a little bit more again, that dacarbazine, the single drug approved for this disease, when I began my training and did my first trial at Yale in 1980, we had hoped would have a response rate of 25%. We had hoped would benefit patients in that fraction. Already in that trial at Yale that we did in 1981, it was a response rate of 13% with this drug, and it's only gone down from there. High-dose interleukin-2, never tested in a randomized phase 3 trial until very recently, and we don't have good data to say that it really is different from dacarbazine, but I think we all believe in our hearts, and I'm very, very much in the same camp as Henry is, that this is a meaningful drug, a worthwhile drug. And this is where we spent, in the middle category, the phase 3 trials negative to date, where we've spent our efforts for the last 10 years, testing elegant new therapies which were leapfrogged from very small pilot trials into huge international trials that consumed hundreds of millions of dollars to no avail, to negative results at the end. And where we'll spend the next 10 or 15 minutes of my talk is where I think recent positive or pending results are encouraging for the future. So, new agents should be smartly pursued. They should build on an understanding of the biology, which we've ignored in many of the past trials. And as Henry's already talked about, one needs to target the fundamental drivers of this cancer. We know those, and as Henry pointed out, and I'll try to emphasize again, melanoma isn't melanoma, isn't melanoma. If a melanoma begins under your nail bed, it's completely different from if it begins in intermittent sun-damaged skin in your chest if you're a man, or on your legs where it's most commonly seen in a woman, and those should not be treated the same, but until recently they have been. Secondly, we should target the deficiencies of the immune system. As a cancer immunologist in my roots, this is where our fondest hope has been. We'll understand how the tumor shuts off the immune response, use that to better then treat the disease, and we'll come back and talk about DCs, dendritic cells, the teaching cells, the instructor cells in the immune system, T cells, the killer cells, the regulator cells of the immune system, which Henry's already introduced, T regulatory cells. We've thought maybe the target of some of these recent modulator trials like the anti-CTLA-4, but that remains to be proven. And then the signaling molecules, not the signaling molecules of the tumor, which we've heard about from Henry and I'll come back about, but now the signaling molecules that the tumor uses to shut off the host, the patient's immune response. And then to reverse chemotherapy mechanisms, which have already been talked about, and we'll try to leapfrog over that. So this is the paper in the New England Journal of Medicine, which first really clearly stated that melanoma is not melanoma, is not melanoma. And you probably can't see it very well, but the left upper corner says BRAF because in intermittent sun-damaged skin, this is where 2/3 of melanomas have a mutation called V600E. That's a revolution. It's a little over 5 years old, but it's already been taken to not one, but several phase 3 trials we'll come back to talk about in a minute. The mucous membranes, I think, I can't barely see it myself, but I think that's what's on the upper right-hand corner. This is where that gene you've already heard about a couple of times, c-KIT, plays its largest role. It's not a majority. We used to think it might be 30%. We might be lucky if it's 15%, but that's better than 0%. And so testing for c-KIT, testing for BRAF are part of the standard lexicon now in our evaluation of almost every patient who comes in with newly metastatic disease. So basically, how do we lump melanomas? Melanomas that are in the soft tissue in the skin are called M1A because they do better than melanoma that are in vital organs like the lung, M1B, or liver, brain, bone, and so forth, M1C. But what makes it different in the beginning of the story, in the skin, for the tumor that can go to the brain as opposed to the other half that don't go to the brain ever in the disease? What makes this process which looks the same to the naked eye, but is able to do that on a PET scan all over the body, every single organ without respect to any boundaries. What makes this difference? Again, we come back to that refrain that I mentioned before. We've got to get the tumor tissue to answer this. And so we've begun studies, and we're in the midst of them, eyeball deep in them now, studying primary melanoma in patients who are going to have sentinel lymph nodes. So we consent the patient when we see them the day we know we want to do a sentinel node biopsy, because we would like to take a sliver of that. It's nothing different in the surgical procedure, nothing different in the cost structure, nothing different in anything else, except that a little sliver goes to the bank to ask what is different in the tumor containing lymph node compared to the tumor-free lymph node. So this study has already got 40 or 50 patients on it. We need 200, so that'll be a long slog. But this study is coupled with a second study where we now take the patient who is going to go to sentinel node biopsy, and we say, it takes us a couple of weeks to schedule this procedure. We'd like to treat you with a lower dose of a form of interferon, and ask, what does that do at the sentinel lymph node? When we wrote this study 2 years ago, I was actually shocked it got funded, but this has proven to be Mount Everest of our trials to try to couple a treatment with a already planned surgical procedure. But this is progress, and we need you to tell other patients to understand why this is so critically important to us. What about the other end of the spectrum? What about brain metastasis? Well, the issues there is exactly as compelling as the original issue at the primary in the skin. A study that we just got IRB approved that was actually presented to the International Melanoma Working Group a year ago and locked into by all the other members of the cooperative group, will profile central nervous system metastases in patients who are going to have an operation on a brain metastasis and compare those against skin metastases, other sites. What will we learn from that? We'll learn if there's a signature of the tumor that's going to go to the brain. How will that help us? It'll mean that when we first see the patient and we see that signature, we will know that we have to treat the brain in anticipation. So this, I hope, is part of the story of biomarkers, of understanding the biology of the disease, the markers that may predict outcome and differentiate those that are bad from those that are relatively less bad. And the IMWG-02 is a name I made up on the car ride here from Pittsburgh, but basically it is the second study that we're planning for the International Melanoma Working Group to couple treatment with new BRAF inhibitors that may work in the brain with the harvest of brain tissue to ask what's going on at ground zero in the treatment of these patients. So this takes us right into the story of targeted therapy, and this has been a true revolution in the last 2 years. BRAF is what I'm going to focus upon. I was going to spend a minute on c-KIT, but you've heard about it twice already, and I think I don't want to bore you. Other cell cycle pathway drivers are waiting to come into this area, and so this complex diagram, which comes from a colleague, maybe a former colleague or a near-miss colleague, I should say, perhaps Keith Flaherty, who's just moved from Penn to Mass General, where Henry had been, basically shows you all of these pathways, mutations that drive this tumor, and that I don't want to get into detail, only to say that we have agents, and all of the boxes here list agents that are now able to inhibit those pathways. So we need to apply these. We need to apply them intelligently. We need to know more about the tumor, and hopefully we'll see at the end this result, which Steve Hodai, again another colleague of Henry's, published, showing dramatic effects in a rectal melanoma of a patient who was very old and wasn't going to get treated with any of the other aggressive therapies like interleukin-2 that you've heard about already, but had a smashing response, stopped bleeding from the tumor, became pain-free, and this is the kind of result we want to have. This is the, I think, hope for the future. So we leapt into this now 6 years ago when the first BRAF inhibitor appeared on the scene. I talked to then young Keith Flaherty and said, we need a protocol for this agent called sorafenib, which was the first BRAF inhibitor. And I tell you this just to be humble so that you join us in being humble about what we expect, because Keith wrote that protocol in a month. It was approved by the Executive Committee in ECOG in a month. It was on the doorstep at CTEP in another month. And then it sat for a year and a half before the pharmaceutical firms decided that they would provide us the agent. But we did it. And it came up with 0. The plum wasn't what we came up. It added not a minute to the benefit of chemotherapy in advanced disease, and it turns out it didn't really hit what we were hoping it hit from the original data. It tells you that we need to do the clinical trials that we set up to do that have become the subject of firestorms in our field of melanoma research. Do we still need to do randomized controlled trials? My absolutely emphatic answer is absolutely yes. We cannot afford to saddle you with wrong results. We need to plod through this in systematic fashions, hopefully more efficient fashion, more rapidly to give you data, but we should not jump the final step and test these in the proper fashion that are now in progress. So PLX 4032, now as a number begins with RG, but you don't need to remember that, basically is a selective inhibitor that has very potent action upon this pathway that Henry's already discussed. This is the result in 2 weeks with treatment with this pill for a patient who has, as you see on the left, hundreds of lesions in the limb affected by this process, which is unique to melanoma, called in-transit metastasis, where the tumor permeates through the lymph vessels in the limb, pops up in the skin, and then erupts elsewhere, and is really otherwise very difficult to treat. Virtually 90% cool down 2 weeks of treatment. Never before have we seen this. This is the first waterfall plot of the phase 1 study when they were looking for toxicity from this agent. Waterfall plots are only in recent years really waterfall plots. A colleague of mine from Chicago used to call them geyser plots because in melanoma, when we followed disease, and here what you have is disease that is smaller going down from the 0 line. All of our old plots used to be lines going up because disease got bigger. Disease got worse during treatment. It didn't get better. Here, with maybe one exception, patients who had the mutation, who got treated with an adequate dose of the drug, had dramatic shrinkage of tumor. So where's the rub? Well, the rub is in the phase 1s, in the phase 2s, now in the phase 3s, which are going on compared to dacarbazine, the benefit doesn't last forever. This is a dramatic response rate, but it is not a durable response rate, meaning years in duration for most patients. We need to fix that. How do we fix that? We need to understand the mechanism of resistance. And you see we come back to the same old story about needing to get tumor tissue. So to overcome resistance is not a unique problem for targeted BRAF inhibitor therapies. It is certainly something that we're now in a major way focused upon in the laboratories. The question is, since we know that there are multiple pathways, should we block 2 parallel pathways, or should we put roadblocks in the same pathway, collimate our inhibitions? The latter has been done and is already suggesting it may be of benefit to inhibit MEK, a downstream pathway participant, as well as BRAF, may be very much better than just inhibiting BRAF. That is the hope for the future. We have chemotherapy mechanisms to inhibit resistance. You've heard about those from the work that Stan Gerson has done here and that Henry is proceeding with now. We've also begun to look at other ways to inhibit resistance to chemotherapy that I won't belabor more except to say that a leukemia drug called decitabine turns on and off genes, and one of the gene sets that it turns off is the genes that are responsible for resistance to temozolomide. So we may be able to couple a leukemia therapy, a seeming leukemia therapy, with a melanoma chemotherapy and have much better results, and those trials are in process. But finally, to take the STAT3 that we talked about before as one of the drivers of tolerance, immune tolerance in patients with melanoma, and turn that off would be a very fond goal of ours. So the story is more complicated. Advanced disease is a much more problematic area than early disease or intermediate lymph node disease. And what this slide shows you is that the complexity of this cancer gets worse when you go from the skin to the lymph node, and it gets even worse when it goes to the vital organs. And so we began studying things, because we're medical oncologists, in brain metastases, in lung metastases, in liver metastases, but it may be that our therapies will only work if we use them at lymph node metastases long before the tumor has gotten, if you will, out of the bag. And so doing these therapies in what is, I guess Ed's comment was add-on therapy, adjuvant therapy, are really, I think, very, very important. And we know the biology of this disease. I think Ed already talked about the increasing risk with the increasing thickness of this tumor, but a thin 1 millimeter tumor is very different from a 5 or 6 millimeter deep tumor. A tumor which has ulceration, the yellow lines, is always worse than a tumor that lacks ulceration. So we know who the bad actors are in terms of melanomas in the skin before we even get past the first pathology, and we should be able to use that to better treat our patients in what is called the adjuvant setting. So these are all the things we've spent the last 25 years pursuing for adjuvant therapy. GM-CSF you've already heard about. Interferon we've spent most of our lives chasing, and I think still is worth considering. Vaccines, the holy grail of immunotherapy. If we could just vaccinate patients against the right markers, wouldn't that be a whole lot better? Interleukin-2, which works in advanced disease, has never been studied as a preventative for lymph node positive high-risk patients who are operable. And finally, anti-CTLA-4. So this is the first 3 ECOG studies that led to the approval of interferon alpha, and basically you've heard this already, so I'm not going to belabor it further except to say this number called HR 1.38, what does that mean? That's the hazard for relapse, similar to the hazard for death, if you do get treated as opposed to if you don't get treated. What 1.38 means is the patient who doesn't get treated is 38% more likely to relapse. The second trial, 24% more likely to relapse. The third and the largest of our big trials compared against a vaccine, 33% more likely to relapse. And these 2 trials, the third and the first of these, both had significant benefit in terms of survival as well. So interferon works. As you already heard, it reduces relapses by, say, 25 to 33%. It reduces mortality by a lesser number, but a significant number. And basically, this is where we are. But we actually have other clues. We know which patients are more likely to relapse from other factors that we can call prognostic biomarkers. And we finally have some markers that can predict which patients treated with this therapy will benefit from it. So maybe, as for interleukin-2, the interleukin-2 select trial that Henry already talked about, maybe for interferon adjuvant treatment, we can just treat the patients who would be most likely to benefit from this therapy. And this is work of Helen Gogas, a collaborator of both Henry's and mine, who's spent very careful effort in Athens sampling the blood of 200 patients who were treated either with a 1-month or with a 1-year interferon treatment, and then asking, in the blood and in the clinical examinations of these patients, did anything else happen that was immunity related? Immunity that is autoimmunity, immunity against skin with depigmentation, against thyroid with overactivity or underactivity of thyroid, or to many other tissues in the body. And so she looked at these antibodies listed on the bottom, and she found a little more than a quarter of patients who developed autoimmunity. So what you say, I mean, who cares? And so basically, who cares is the patients who got this. And it's amazing that we had dozens of patients who had thyroid autoimmunity, overactive thyroid, underactive thyroid, and we didn't put 2 + 2 together because those are the people who didn't relapse. Those are the people who didn't die with melanoma. And so Helen's data just gave a number and a graphical plot to this, that the patients who had autoimmunity, the top line here on the left for relapse, the top line on the right for survival, were the people who didn't relapse and didn't die. And this story of autoimmunity being associated with the benefit of interferon is a replay. It's a replay of story that Mike Atkins, a colleague from Boston, published in the late 80s, where for interleukin-2, the exact same thing is true. So a patient who gets autoimmunity on interleukin-2 does much better. A patient who gets autoimmunity on interferon doesn't relapse, doesn't die. And we'll see this come back once again, but you say, this doesn't help you because you only find this after you treat the patient. So we said we've got to look at the beginning of the story in the serums that we have in our banks from the past ECOG trials and ask, is there anything in the blood of the patient at the beginning of the story that predicts who will not relapse? So we've done this. Here are 3 different cytokines. Cytokines are hormones of the immune system. Interleukin-1 beta, interleukin-6, tumor necrosis factor. You don't need to remember those, but these are all signals of the immune system which are up in only some patients. And when we group patients by those on the right who did well 5 years later, as opposed to those who within a year or within 1 to 5 years had relapsed or died, we see that people who had this set of hormones in the immune system up were the people who were living 5 years and more doing well. So the beginning of the story, before treatment, we have a profile of, it turns out, 6 cytokines, which allow us to predict who would benefit from this toxic therapy so that we might only treat those patients. In that same trial, we actually had a vaccine treatment, and that's the bottom line. The vaccine recipients, we said, are a perfect group to study to ask, is this really just a predictor for who was going to do better, never mind the interferon? And what you see is that there are no little asterisks, there are no significant differences in those who lasted 5 years without relapse as opposed to those who had a relapse and died within a year. And so this is the data that suggests that this is a predictive factor, not a prognostic factor. This is something which tells us who can benefit from the interferon, and we are pursuing this now in very much larger studies by very much more complex technology. So you've heard about 1697, and I'm going to fly through this because the time is late, but this is the study which asks whether we need to be as toxic as a whole year of therapy to get the benefit we want out of interferon. Since all the trials that we'd pursued that had a survival benefit used 1 month of intravenous therapy, we said maybe that's it. Maybe that's necessary and sufficient. So the current trial, 1,420 patients. Happily, we're over 1,200 now, so I really hope that we can continue and finish this, may tell us that that 1 month of therapy does the whole trick. And if that were the case, we could save our patients 11 months of discomfort with this therapy, which to the present we don't know is possible. A new form of therapy that I'm going to tell you twice about this morning in the remaining time I have is called neoadjuvant therapy. This is taking a patient who has a lump in a lymph node, would be treated by first the surgeon and then by us, and saying we're going to reverse the sequence. We're going to offer these patients who have a lump in a lymph node a biopsy to prove that it is what we think it is, and we're then going to treat them immediately, within days, with the same treatment that we think has benefit, maybe the life-saving benefits of the therapy interferon. And so that trial called 00008, should have been 007, basically was biopsy the minute you see the patient, treat for a month with interferon, and then do your surgery, because this is treatment with the interferon for the distant disease that might otherwise be the life-threatening disease in these patients. So what do we find in this trial? 20 patients enrolled, all had bulky lymph node disease. Most of them had completed the therapy with 4 weeks of therapy without need to come off treatment. Objective response according to criteria that we accept in the field at the 4th week of treatment, 1 complete response, 10 partial responses without any surgery in these patients. And so we looked under the microscope, and now we had 3 pathologic responses, no tumor cells left after just the 4 weeks of the interferon. And then we looked at the tumor tissue, before on the left, after on the right. You don't need me to tell you that there are more of the red dots, which on the top are T cells, on the bottom are dendritic cells or instructor cells. So now you know how interferon works. We didn't learn it until we did a study that was just published 5 years ago. This tells you that interferon works by driving T cells and dendritic cells, the immune instructors and fighters of your system, into the tumor. So interferon is de facto like a vaccine. And this was a revelation to us. It was not possible to find in other ways. And so then you say, why does this drive the tumor cells, the T cells and the dendritic cells into the tumor? And then we look for those signaling molecules that we talked about before, STAT3, which seem to switch off the immune system. The tumor tells the immune system, don't touch us, by exuding this signaling molecule STAT3. And basically, STAT3, present in the beginning, gone after 4 weeks of treatment. So this is further understanding that we could only have gotten by a neoadjuvant approach, studying tumor tissue before and after. And this is just a graphical depiction of the STAT3. The other thing that's remarkable here is that 55%, 11 patients, had benefit with interferon. We've treated hundreds and hundreds of patients with interferon before that. We never got a response rate over 15, 16%. So it says that interferon treatment earlier in the disease gets you better mileage, is more effective. So this is, I think, the lesson that we learned, that we should do neoadjuvant studies far earlier in the history of our treatment approaches. So anti-tumor vaccines, something that had been mentioned in terms of current trials here in Cleveland, a major focus of the group that we have, and a story which actually was capped by a study presented a year ago at the ASCO meetings of 2009 by Doug Schwartzentruber, where he added a vaccine to the same old therapy you heard about from Henry, interleukin-2, and he showed statistically significantly improved outcome. Overall response rate went from 10% to 22%. Progression-free survival went from 1.6 months before disease got larger to almost 3 months. And overall survival was also improved, but with the numbers they had in this trial, the significance for that benefit is a little less than for the other two features. Picture's always worth 1,000 words. So this is vaccine in the red added to interleukin-2. This is interleukin-2 alone. And this is a randomized, properly done study that suggests vaccine adds to this old warhorse of our therapy, interleukin-2. So we don't really have that vaccine to offer patients, so the clinical significance of this is not clear yet. I think selecting patients, as the cytokine working group is now planning to do, makes very much better sense in the immediate future. And basically, one other approach is to add some therapy that will block the resistance factor. The factor is called VEGF, and vascular endothelial growth factor, VEGF, basically has an inhibitor that we've been studying for a couple of years, which is very promising and also will be pursued as a phase 2 trial with IL-2 to try to improve response to that under Ahmed Torini's leadership. Then to turn to vaccines and try to add them intelligently. So Henry's already mentioned this trial of the MAGE-A3 vaccine, but the truly remarkable thing about this is that patients who have tumors studied for the profile of those tumors can be predicted whether they will or they will not be responsive to the MAGE-A3 vaccine. So in this trial, that's why we have to go through the pyrotechnics of getting the tumor samples to the sponsor to assess the tumor for the signature. And in fact, the signature, the green and the red dots from the patients who are responders on one side and non-responders on the other side are very different. So for this vaccine, like for interleukin-2, like for interferon alpha, our hope is we can pick the right patients and do it in only those patients who will benefit. So this is the schema. You've already heard about this, so I won't belabor it further. And finally, to the Epilimab story. So you've seen this, that this molecule, an antibody illustrated in the stick figure by the Y-shaped molecule, blocks up the molecule that is on the surface of the T cell and many other immune cells and prevents it from signaling. This is an off signal. This is a checkpoint molecule. So this inhibiting the inhibitor gives you a more positive outcome. It, as Henry pointed out, it takes off the brakes from the immune system. And so when this was first tested, and there are two of these, and I should mention that tremelimumab, we'll come back to mention very briefly, is the other one, slightly different half-lives, different type of antibody, but in the end, very similar situation in the clinic. Looks to work better at 10 milligrams than at 3, than at 0.3. Overall survival median in months, 8, 8.7, 11.4. So we think that the dose of 10, for a variety of reasons, is the dose to test. The phase 3 trial that we've mentioned, that we'll come back to talk about, was actually testing a lower dose, this dose of 3. So we're going to have to figure out what we do with that if we get this through the FDA. You have heard about the side effects, and so I won't belabor these, but I figured you, as the community, will be very important to understand the skin, the GI, the pituitary, and the liver, pituitary, I should say, endocrine, and the liver side effects, because these can be fatal. The immune response adverse events, IRAE, are a profile that is very different for this antibody molecule than for almost any therapy we've tested before. So it's going to stretch us as oncologists and stretch our peers in the community even more, because one has to know these side effects in order to safely give these drugs. Basically, the rashes, we say, are tolerable. Our patients aren't always sure that that really is as tolerable as we would have it. But this gastrointestinal immune response adverse event of colitis is a very big problem. This is a 15 to 30 and maybe even 40% risk, and it may be more in patients treated earlier in the adjuvant setting, so we need to be attuned for that. Biopsy usually shows an inflammatory colitis like other inflammatory bowel disease, but it can lead to perforation, and this was seen not only with Epilimab but also with Tremelimumab. And at a 1% fatality or 2% fatality rate, we have to think twice about how early we deploy these therapies in the treatment of this disease. Hypophysitis. The hypophysis is a little gland in the middle of the brain, which is the master gland controlling organ in the brain, basically the driver of all your other endocrine organs. And basically, this can become inflamed. Part of the autoimmune response with Epilimumab, it can be isolated, or there can be adrenal or other dysfunctions, so that we need to be much better doctors than perhaps we all had wound down to become, to be able to pick up these subtle endocrine effects of this new therapy. Hepatitis, a major effect. We can monitor this, of course, in blood tests, a little less of a risk, but it means the patient cannot be taking any other things that can damage the liver while they're taking this therapy. So management demands that we know, that our treated patients know, that their families know about these side effects, and these are the two big trials that we're, in one case, going to talk about. The second-line trial, MDX20, which has already been presented, but the bigger trial of the combination of chemotherapy, dacarbazine with Epilimumab, compared to the chemotherapy alone, is still under wraps. We don't know what the results of this are, and it may be 2011 before we get to that. So this is the presented study that was, I think, the talk of the day at ASCO. Steve O'Day presented for the study group, including many of our institutions, where the antibody plus a vaccine was compared to the antibody plus placebo, and was compared to the vaccine peptide alone. So these, and I think you've seen this already, so I'm just going to say that they were very well-balanced groups, show that the antibody-containing arms did hands down better in terms of survival than the vaccine arm. And the vaccine arm actually tracks very closely to the meta-analysis that I showed you already, so we believe these are probably real and valid numbers. But when we look at 2 years, the bottom line you see here, what is the difference we have with Epilimumab? Well, the difference is 14% with the vaccine to 24, 22% with the combination. This is back to our same 8, 10% that we see with IL-2. It's probably a different 8, 10%, and it's done in a randomized, rigorous fashion, so we believe these data, but we still need to make a whole lot more progress than we have here. Best response rate, 5%, 10.9% is another wrinkle. Why doesn't this treatment objectively shrink disease at the same time that it's preventing death from this disease? And the more interesting question, and one that was asked by a patient's daughter who accompanied me here today, the minute she saw these data before, is why is the vaccine diminishing the benefit of the Epilimab. So this first column is vaccine, GP100, plus Epilimab. The second column is Epilimab alone. And in this comparison, why is the best observed response rate half with the vaccine added to the Epi what it is when it's there alone? Why is the disease control rate less when you add the vaccine? And we do not understand this. I just put it on the table because there are lots of questions we still have to answer. The side effects, major issues for us as a field to deal with. Deaths due to these adverse reactions, 1.3, 1.5%, is something that we all take with great concern. So this is a clearly new arena. This is the first positive phase 3 trial. The consistent superiority of Epilimumab, I think all of us believe, warrants it being approved by the US FDA as it comes to review later this year. But this reduced progression-free survival, best observed response rate, and disease control, when you add a vaccine to this, is a real thorn in our side. Why? Because in the mouse, where this whole approach was born, when you added vaccine to the anti-CTLA-4, it improved the benefit. It was that entire finding that we hoped would allow us to give better vaccines that propelled anti-CTLA-4 into the clinic. And that very hypothesis has no support anymore in the trial MDX20. The toxicities are concerns. I think it's late enough that I'm going to fly through that. And the final concern is that another company, not Bristol Myers Squibb, but Pfizer, had a very similar antibody that we've already compared. This tremelimumab was compared head-on to chemotherapy. And although the tremelimumab in green is always doing a little bit better than the chemotherapy, it's pretty close. And it was too close for them to stay with it, and they've dropped this entire approach so that the other big anti-CTLA-4 isn't being pursued at all in the clinic any longer. Part of the answer for this may have been that people could get the expanded access Epilimumab, and people who got the dacarbazine went out the front door and came in the back door someplace else and got the same antibody or a similar antibody as salvage. And it may be that treatment later with this agent may get us the same benefit that treatment earlier does. This is a big problem for our field because it may mean that we no longer can go for survival endpoints in our studies. So the conclusions, this is a clearly promising agent. The responses aren't the same, are not congruent with the survival benefit. But how to take this ahead? How to make better results out of this antibody to CTLA-4? The EORTC, the European Organization for Research and Treatment of Cancer, has already begun a trial of Epilimumab versus placebo. This is not yet complete, but this is a trial which will test, to the greatest benefit of the antibody, its benefit. Here, where interferon is an established therapy, what we really need to know is Epi any better than interferon? And this trial has been reviewed for months now in Bristol Myers leadership, has finally gotten through their protocol review committee, and we're hoping in the next several weeks will achieve their final level of approval. But it's ready to go. In the ECOG, it's been approved. In the CTEP, it's been approved. Even in the central IRB. So this is really Epilimumab versus interferon, the next likely intergroup trial, hopefully to start before the end of this year to test this new promising approach to therapy, which has different, not substantially less, but different side effects than the interferon, and to ask both in terms of relapse-free survival and in terms of overall survival, because they're co-primary endpoints now, are they any different? We weren't content to have the black box that I think we've been given with Epilimumab, so we said, let us test this in the neoadjuvant setting. So we now have 14 patients who've gone through the exact same kind of treatment that I told you about before that we did with interferon 5 years ago. And these patients with bulky stage 3B and C disease get a biopsy the day we see them, are enrolled into a treatment with 2 doses, day 1, day 22 of Epilimumab, and then at day 42, 6 weeks, come to definitive surgery. And in that tumor tissue, we hope we can understand the basis of benefit from the Epilimumab. Clearly, single drugs are going to be unlikely to harness this whole disease in the advanced setting. How to combine these is the story for the future. Combinations of interferon and anti-CTLA-4, Ahmed Tarini has already presented to ASCO. Substantial anti-tumor impact, survival way past a year, response rate of 30%. This looks like it's additive, and I think we're going to pursue this further. Antibodies that kill melanoma cells, an antibody called KW2871, we've been studying with the Ludwig Institute, added to interferon. Finally, taking vaccines, because we know vaccines are a way to prime the immune pump, and adding them to interferon, which already acts like a vaccine. And Lisa Butterfield in Spore Project 2 will be testing this. The vector has been prepared. We're about ready to start this in the clinic, and I hope that'll happen before the end of the year. So this is the next generation of targets. We haven't talked about any of these other signaling loops that drive the immune system forward. There are also loops that are regulatory ones, PD-1, a very exciting new target that may be as good or better than anti-CTLA-4 blocking antibodies. Hassan Zarour, who's shown that TIM-1 is maybe even better than PD-1. So many things that we think will allow us to better prime the pump, the immune pump, against this disease. So, in summary, we understand a whole lot more about this tumor and about the host immune response. We also understand how little we still know about this tumor and the immune response, and we have a whole variety of new ways to approach this disease. I think end with this, and thank you for your attention. I should also thanks to all the supporters of the work we do, and especially to our patients who, without whom we would not have done any of this. Thank you.